or cryoneurolisis. It's a specialized technique for providing long-term pain relief in an interventional pain management setting. So, people who do interventional pain management are pain physicians. So, it is one of the tools used by pain physicians. Modern cryoanalgesia goes to Cooper. History, everything you said, but it was Lloyd et al. Who coined the term cryoanalgesia for its pain management. And the clinical application of cryoanalgesia extends from its use in craniofacial pain secondary to trigeminal neuralgia. This was the first chronic pain for which they tried it. And the second condition was posterior auricular neuralgia and glossopharyngeal neuralgia. These are all the conditions for which first they tried this method and found good results. Then later on, they extended it to chest wall pain with multiple conditions, including post-thoracotomy neuromas, persistent pain after rib fracture, and post-herpetic neuralgia, which are all again chronic painful conditions. And then abdominal and pelvic pain secondary to ilioinguinal, ilioepigastric, and genitofemoral, all these neuralgias. What she mentioned in indications, these are all the conditions for which they were using this. And later on, for various types of peripheral neuropathy and upper extremity pain secondary to suprascapular neuritis and other peripheral neuritis also were treated with this. Now, the physics and equipment, as he rightly said, the probe consists of a hollow tube with a smaller inner tube, and pressurized nitrous oxide or carbon dioxide at 600 to 800 psi travels down the inner tube and is suddenly released to the target area, where the pressure becomes suddenly low to 10 to 15 psi through a very fine aperture of 0.002 millimeter, which allows the gas to rapidly expand into the distal tip. So this extracts heat from the tip of the probe, resulting in a temperature as cold as minus 89 degrees centigrade at the tip. This is what is called the Joule-Thomson effect, forming an ice ball with the temperature in the range of minus 70 degrees. This Joule-Thomson effect, those of you who have the habit of using a nitrous oxide cylinder in your anesthesia machine. Nowadays, most of the hospitals have workstations which have the central pipeline supply even for nitrous oxide. But in the olden days, when cylinders were attached to the anesthesia machine, when we open the nitrous oxide cylinder and start using it, after a few minutes of use, if you see the nitrous oxide outlet valve will be forming a layer of ice over it. And that is because of this Joule-Thomson effect, where the pressurized gas of nitrous oxide inside the cylinder, when it gets released outside, there is a drop in pressure, and the surrounding atmospheric air, which has the water vapor, gets solidified and then forms as a small ice droplets on the outlet near the valve. So that is commonly seen in the nitrous oxide cylinder. The same principle is used here, where there is when the sudden expansion of a gas under pressure, it extracts the heat from that and forms the ice. This gas then vented back to the machine itself through the outer tube and is scavenged through the ventilated outlet. So this is a closed system. So if you see this picture, rather than the probe picture what Saranya showed, this is the outer tube, and I mean this is the probe tip. So the cold pressure gas is coming out through that. This is the warm stem. So when the gas is released here from high pressure, there is a sudden drop in pressure and it forms a big ice ball. And after dropping the temperature here and forming the icicles here, the gas goes out through the outer tube and goes back to the machine. So no gas will expel out. Otherwise, you will get a situation like a surgical emphysema. So because this is a closed tip and the point of this opening is here, this layer has been cut, the outer tube has been cut to explain how this is working. So imagine the whole thing is closed and there is an inner tube through which the highly pressurized gas is coming, and there will be a drop in temperature, and this ice ball will form here, and whatever gas is remaining will go back through the outer tube back to the machine. That is why this is called a closed system of construction of the probe, and machine assures that no gas escapes to the patient tissues. So there will be no formation of any cervical emphysema like thing. Otherwise, what will happen with the high pressure? If all the gas has to spread all over the tissues will get disrupted, and we will get a damage to the tissues. But because this probe is having a very fine opening of 0.002 millimeter, only a small bit of this gas will come out, and because it is suddenly losing all the pressure, it will form an icicle there, and an ice ball will be formed. So when the ice is formed very close to the nerve, it acts on the nerve. So the 2 mm probe forms a 5.5 mm ice ball, and if the probe is much lesser than that 1.4 mm, then the ice ball size will be only 3.5 millimeter ice ball. And precise gas flows are necessary for safe and effective cryoneuroablation. Inadequate gas flows will not produce an ice ball, while excessive flows can cause freezing proximal also to the inside the probe and cause risk of burns. And the probe also includes a nerve stimulator usually to identify the nerve correctly and then deposit this ice ball. This ice ball is the main thing to cause the action of cryoablation. So this has to be localized or placed exactly very close to the nerve which we want to ablate. Now coming to the action of cryo, how it acts, the application of cold to tissues creates a conduction block similar to the effect of local anesthetics. That is why in the olden days, as she mentioned, we were using ethyl chloride spray for small procedures like IND or necking a wart or small superficial procedures. All were done under ethyl chloride spray, which produced cooling of the surface and produced a effect similar to local anesthetic, and but the duration will be very short. Uh, at 10 degrees centigrade, large myelinated fibers stop conducting, but all nerve fibers stop conducting at minus 20 degrees centigrade. So as the temperature goes down, the conducting ability of the nerve is automatically blocked. The extent and duration of the effect is therefore a function of the degree of cold obtained and the length of time of exposure. So the two factors determining the duration of block are the strength of the cold. The more colder it is, more longer the duration. More longer the exposure of this cold to the nerve, more longer the duration. And long-term pain relief from nerve freezing occurs because ice crystals create a vascular damage to the vasa nervorum, which produces severe endoneural edema. This is the first reaction that will happen. When a nerve is exposed or frozen by the ice crystals, it damages the vasa nervorum. That is, the blood supply to the nerve is first affected, causing an endoneural edema, and the endoneural fluid pressure increases about 20 millimeter within 90 minutes of cryolesioning. And changes in the elastic properties of the perineurium causes a decrease in extracellular fluid pressure within 24 hours, which increases again and reaches a plateau about 6 days post lesion. So it is a immediate initial edema will happen, but this will last for almost 6 days. And this disrupts the nerve structure, creates what is called a Wallerian degeneration, but leaves the myelin sheath and the endoneurium intact, and the swan cell based lamina is spared, and ultimately provides the uh, opportunity for regeneration. Now, there is another autoimmune phenomenon also implicated in the long-term effects of cryoneuroablation, which causes a release of sequestrated proteins that may trigger an autoimmune response to the targeted lesion tissues, which might explain the prolonged effect. So, apart from this Wallerian degeneration, this autoimmune phenomena where the proteins that are released causing this response is the another reason for the longer duration of pain relief. The extent of freezing in subsequent nerve damage is a function of one, how proximal the probe is to the nerve. It should be as close to the nerve as possible. And what is the size of the cryoprobe, whether you are using a 2 probe or a 1.4 and the size of the ice ball that is formed, the completeness of freezing, that the rate and duration, and the temperature of the tissues in the proximity of the probe, which is affected by local heat sinks, that is like CSF or blood. The intensity and duration of analgesia is dependent on the degree of nerve cell damage from the ice ball. So ultimately, it is the ice ball which causes these reactions to provide the pain relief. But the factors controlling are the proximity, the size of the cryoprobe, the size of the ice ball, and the freezing rate and duration, and what are the temperature of the adjoining structures in the nerve which we are trying to ablate. Now, current probe ranges from 1.4 to 2 millimeters, as I said earlier, and most of them have a built-in nerve stimulator to localize the nerve and a thermistor to identify the temperature. So there are two things which are attached to the probe or incorporated in the probe. One is the nerve stimulator to localize the nerve. The second is the thermistor to identify what is the temperature achieved. And the nerve stimulator allows a frequency choice of 100 Hertz to for sensory 100 Hertz and motor 2 Hertz responses. And use of an introducer is recommended because the introducer can be used to infiltrate local anesthesia and isolate the electrical current from the stimulation to just the tip of the probe. So it can be just a Venflon. So you can use a 14 or a 16 gauge Venflon with the needle first go close to the nerve by either ultrasound or using this nerve stimulator. Then remove the needle and then insert your probe through that Venflon. So that is the technique. That is what is called the introducer. So the so that you can protect the other areas and the tip only will be close to the nerve. The commonly used introducer is a large gauge IV catheter. The sharp tip pierces the tissues more easily than the probe itself, and the stylet can be removed to allow introduction of the probe. And a 12 gauge catheter used for 2 probe and 14 or 16 for the smaller probe of 1.4 Clinical aspects, it's critical that precise diagnosis be made prior to an attempt to freeze any nerve. In fact, the first step is to confirm that pathology is primarily isolated only to the sensory nerves. That is very important. You cannot do it in all sorts of myositis or other anatomical structures from which the pain is arising. And the use of a nerve stimulator as well as fluoroscopic guidance, direct exposure or absolute anatomic location are all very much important for selecting and ablating the nerve. And success of cryoanalgesia is directly related to the patient selection, accurate probe placement, and post-procedural rehabilitation. All these things have to be taken care of. Now, patient preparation, how do you do that? Informed consent is important as this technique is for any other intervention procedures. Risk, complication, and specific contraindications should be discussed and then discussion documented. This is very, very important because chronic pain patients are always troublesome patients. They come with a lot of expectation, and if the procedure does not give satisfactory result, they won't mind suing you. So they are very troublesome patients. So we have to discuss all these things and document it. The machine and gas supply should be checked and the cryoprobe purged at room temperature air gases. The patient is placed in an appropriate position and the nerve location confirmed by palpation and when appropriate by fluoroscopic localization also. And minimal, if any, sedation should be used because if you sedate too much, sometimes the patient may say that he is not feeling the pain at the time. Later on, he may start complaining. So The patient should be awake and should be able to respond to the stimulation. So the sedation that you give should be very, very low. And the technique, of course, she described that the technique requires precise localization of the target nerve. Again, this is repeated again and again because of the importance that we have to go very close to the target nerve. And depending on the anatomy, the ease of locating the landmark, cryoneuroablation can be done with or without fluoroscopy. Then you sterilize the area, prepare and drape as you do for any procedure, and a small amount of local anesthetic is given only subcutaneously. Don't go too deep close to the nerve. Then the nerve will block the sensation. The local anesthetic will block the sensation and you will not be able to elicit the desired response. Then a 27 gauge 1.5 inch needle is then advanced into the subcutaneous tissue and 1 ml of saline with freshly added epinephrine is infiltrated for hemostasis. A small incision is made in the skin and an IV introducer, that is our Venflon, either 12 gauge or 14 or 16 depending upon the probe that you are going to use. You introduce and advance it to the target area. Now a small dose of additional local anesthetic can be injected through the introducer as it is advanced, taking care not to anesthetize the actual target area. So this local anesthetic is only for the other structures through which we are going to pass if it is going to be quite deep. And when the introducer comes in contact with the target area, the stellate is removed and cryoprobe is then advanced through the Venflon outer sheath and through the catheter, the tip of the probe exposed by withdrawing the catheter into the subcutaneous tissue. So once the probe has gone close to the nerve, you pull out the Venflon a little bit into the subcutaneous level. Most of the technique described use the bone as a backstop. If there is a bone underneath the nerve, then that can be used to pin the nerve. So you can fix the nerve on the bone so that it doesn't become mobile, and it will be much more precise than using it in a soft tissue. Now, contraindications, general contraindications like percutaneous bleeding disorder, infection, and uninformed patient, all these things you mentioned. And so just to understand the anatomy of the nerve, this is a mixed nerve. So the outermost covering of a bundle of nerve or the fascicles is the epineurium. And if you see the close-up view of this, there are a lot of fascicles, and each fascicle has a lot of nerves, and these fascicles are covered by what is called the endoneurium. And these multiple fascicles are clubbed together into a nerve, and the outer covering of that is called the epineurium, and the outer covering for the entire fascicle is inside the epineurium is the perineurium, and the individual covering for the nerve fiber in the fascicle is the endoneurium. So there are three layers: endoneurium for individual nerve fiber, multiple nerve fibers bunched together is called a fascicle, which has got a perineurium, and multiple fascicles covered by epineurium. So this is the entire structure, and we are going to go close to the perineurium. So if you retain this perineurium, regeneration will still happen. If you use a neurolytic agent like phenol or alcohol, all these layers are destroyed. So nerve is totally, completely destroyed so that there is no sensation at all, and that area becomes anesthetic and pain is also gone, but the patient will have lack of sensation in that area. So that area will become anesthetic also. Whereas here, initially, for quite some time, you will have a pain relief because the blockage is happening. But later on, the sensation will return. And once you break the vicious cycle in a chronic pain, patient will feel better. The pain will not come back, and the nerve also will regenerate, and the patient will get back the sensation. That area will no more be anesthetic. So that is the advantage of cryoanalgesia. So again, this is the axon, this is the myelin sheath, so myelinated nerve fiber, unmyelinated nerve fiber. So if you remember this structure, it is very easy to understand how this is going to act. So the two main mechanisms by which cryoanalgesia produces its action is, one is the neural edema, endonural edema. So endoneurium inside there is an edema, and there is a autoimmune response by the protein form that is released. So these are the two things, but the duration of pain relief is very short in cryoanalgesia compared to other techniques. Okay, so that is how it acts. Right. Okay, so there are no doubts about that. Shall we go to the next talk?